Up next, we have Dr. Kseniya Yershova. She is the Deputy Scientific Director for the Center for Suicide Risk Assessment and is based at New York State Psychiatric Institute and the Columbia University Medical School. She works in outpatient, inpatient, and emergency services and conducts field assessments for state and international programs and has been very involved with leading the psychometric validation work for the Columbia Suicide Severity Rating Scale. So I think that you will find what she's going to talk about with regards to assessment really relevant in many applications today. So join me in welcoming Dr. Yershova.
I decided I'll actually start by reference to, I guess, where my first connection to the topic came from. I was sitting and reminiscing and realized that when I started training, trained clinical psychologist, my first 3 adult patients, is it echoing?
It's a little too quiet, so if you can lift that up, or can we turn up the volume?
Hold on a second. Okay, so, first 3 patients. Obviously didn't know what I was doing, just started. And all 3 patients, the first one was a woman with chronic skin condition and chronic self-injurious behavior. And what I learned by working with this patient and 2 others was that personality organization really matters. And this first patient was, in fact, a patient with a borderline personality disorder. And I have to say that what, besides just this was a very humbling experience, to start with a patient with a borderline personality disorder, narcissistic personality disorder, and schizoid personality disorder as a first-year student. I can say that what really helped me understand and begin to learn how to be with patients and relate and hopefully do clinical work is sitting with a supervisor who was a very close, unfortunately he's no longer with us, a very close colleague of the developers of mentalization-based approach to treatment of borderline personality disorder, who developed an instrument for looking at psychotherapy process. And that instrument, what was particularly remarkable about it, is that it was pan-theoretical. What I mean by that is that you could apply that instrument when you're looking at psychotherapy process, whether it's CBT, DBT, IPT, psychoanalysis, it didn't matter. It translated all of our interventions into common language. And consistently applying and looking at clinical material with that pan-theoretical method that gave common language was incredibly important in seeing patterns and arriving at real understanding. And I give you this frame because ultimately what I'm going to talk about today is an instrument. It's one method of assessing, identifying, detecting suicidal ideation and behavior. And what I'd like to do is to make this talk very hands-on, okay? And apply it to many contexts. So I will echo some of the things that Nicole has already covered, but mostly focus on the instrument and the method. So this is, at this point, I think this has become a common refrain that 50% of people see their primary care provider people who die by suicide in their month before they die. And 25 of people who die by suicide are seen in the emergency room in the past 12 months for non-psychiatric reasons. And many attempters in the emergency rooms are, including adolescents, are there for not psychiatric reasons. So as Nicole has already addressed this, rising mortality and morbidity associated with suicide across many groups, and very significant rise in suicide rates in the last decade. And some of you may be familiar with a study that was published in the last year that really, before the last CDC report that just came out, was a serious kind of a light bulb moment for those of us in suicide research that looked or found that particularly in the white, non-Hispanic men and women of middle age, the rising mortality was just unprecedented. And the three main causes were poisoning, substance poisoning, suicides, and liver disease. This is the United States. This is in contrast to what was happening before. And this is in contrast to what's happening in other countries. So this is US. Oops, sorry. Oops. So this is US, right? And this is all of, not all, but some of the other European countries. And this is what's happening to mortality rates there. So this is from the most recent CDC report, and Nicole already mentioned this, the dramatic increase in women, of suicide rates in women, girls. And I don't really need to cover this, but mental illness is a very prominent factor, and 90% of people who die by suicide have mental illness. And many, and this has been highlighted this morning, do not receive the treatment that they need. Okay, where am I going with this, all of this? What I think this tells us is that suicide risk, even though it is typically or historically has been perceived as a psychiatric issue, really cuts across, affects people across medical conditions, settings, and demographic groups. And the entry point for asking about suicide, suicidal thoughts, and behaviors is way upstream from psychiatry. So, and connecting this to my, I guess, overall underlying theme of developing a common language, this is not my message, this is World Health Organization, this is data from the programs that are actually successful in preventing suicide. Coming together across sectors is incredibly important, and understanding how we talk about risk, giving vocabulary, is incredibly important. So these are just, I outlined some basic domains of clinical suicide risk assessment, or forget clinical, suicide risk assessment, and really just to point out where my talk is going to focus on. We can't really expect anyone to ask about suicide, whether it's nurse, whether it's a police officer, whether it's a psychiatrist, whether it's a nurse, unless there's a belief that you can prevent suicide. And so the question is suicide preventable? Can I ask? Those are some of the questions that that we have to answer in the affirmative. And accurate risk assessment is the domain where I'm really going to spend most of my time. What do we ask and how do we ask? And how do we put suicide risk into language that all of us understand? Okay, so let's just look quickly at some of the common beliefs that when we talk, when we do some sort of program evaluation, we actually ask about people's beliefs, and then look at attitude change, and then look at what changes as far as how consistently different settings begin to ask about suicide. So these are some of the thoughts that and attitudes that come up over and over again. There's no point in asking about suicide, because if someone's going to attempt suicide, they will not tell you. The reality is that many will. When you ask directly, unambiguously, and 80% of people who die by suicide give some indication of warning. And the state of human condition is ambivalence. No one is dead sure, pun intended, that they really want to die. Okay, very, very few people actually have that kind of 100% confidence. Asking a depressed person about suicide may give them an idea about doing it. So asking does not suggest suicide or make it more likely. We do have to worry about suggestibility, contagion, but this is not where we worry. How media covers suicide is where we worry about suggestibility and contagion. But asking directly about, have you attempted, are you thinking about X, does not produce suicidal thoughts and make somebody more suicidal. So if you stop someone from killing themselves one way, they'll probably find another way to do it. So means restriction, although I have to, this is a side note, in our work with the military, we found out that this is not a favorable expression, and as soon as you start talking about means restriction, you really lose most of the audience when you're talking to military. So the idea really is that interventions or suicide risk prevention programs target lethal methods. And that really has strong evidence of efficacy. So here are just a couple of examples. England changed from bottles to blistering packages of Tylenol, and they saw 44% reduction in Tylenol overdose in 11 years. So just by restricting the ability to do this with the pills, and extending the time that it takes to pop those pills out, you produce an important effect, protective effect. Israeli military, 2006, restricted gun access on weekends. Look what happened. The suicide rate dropped by 40%. Okay, if someone is really suicidal, they are probably going to kill themselves at some point, no matter what you do. Most people are suicidal only for a short period of time. This is why I just emphasized Tylenol example. Time is a factor. Many suicide attempters do not go on to die by suicide. So what do we ask? How do we ask? This study shows how important one word can be in changing prevalence rates or our estimates of how frequently suicide happens. So in Ron Kessler's study, the reanalysis of the National Comorbidity Survey, once they started requiring intent to die in the definition of suicidal attempt, the lifetime prevalence in the United States, their estimates, of self-reported suicide attempts dropped from almost 5% to 2.7. So this is getting at the distinction between different forms of self-injurious behavior, but the point is that definitions have a serious effect. So I'm going to tell you a little bit about where this instrument came from, because the story is telling, pun intended again. So a decade ago, there was a group of researchers, some of them are in the audience, who were working on the first really amazing study of treatment for adolescent suicide attempters. At the same time, those of you who remember, there was the black box controversy, what became a black box, surrounding the issue of antidepressants potentially increasing suicidal ideation in adolescents. FDA, when they looked at all the adverse event data, they became worried because they realized that there was no consistency in how these potentially suicidal events were labeled. So they came to Columbia, they came to this group of researchers, and that really gave birth to the system that or the method that I'm going to be describing. So when the team looked at all the adverse event descriptions, there were 38 discrepant ratings. What would you guess was the category with the least agreement? Specifically on suicide attempt. What does it tell us? We can't agree on one category that we think we all know what it is. So, and then the consequence of this reclassification was, again, something similar to what I just told you about Ron Kessler's reanalysis, that the rates of suicide attempts were lower. Okay, these are just some examples, and I think they really drive the point, some of the points home. On the left, you see the original labels for the clinical descriptions of events, okay? So let's just look. The patient took 11 tablets impulsively and then went to school. The patient denied that it was a suicide attempt. Medication error. After arguing with his stepfather, 10-year-old boy wrapped a cord from the mini blinds around his neck, threatening to kill himself. Hostility. That was the label that was given. Hitting his head on the wall, the patient explained, "It is like my thoughts are about to explode." That was labeled as suicide attempt. So, what would it take for this event to be labeled medication error? This boy took it by mistake? Whose medication error? And what would it take, how would one arrive at a label like this? My explanation is that the subjective feelings of the rater arrived at this label. And the rater probably thought, oh, this was manipulative, this was intentional behavior towards the parent. So the point of the instrument ultimately is to take that out, that subjective feeling about what is really happening, okay? And stick with the descriptions. So, and if you notice, the misclassification or misdescriptions happened in both directions. So it's not like there was some sort of an intentional decision on the part of the rater to underrate or overrate. Okay? So the instrument, the Columbia Suicide Severity Rating Scale, was developed, as I said, in the NIMH trial of treatment for adolescent suicide attempters. And the specific focus really was on measuring ideation, behavior separately, have both categorical and dimensional indicators of ideation and behavior, such that you would actually be able to track change over time. So I'm going to skip the description of the study, except to say that this is an adolescent sample. And in a nutshell, this is the scale. There are 4 parts to this method. Ideation, suicidal ideation, suicidal behavior, and dimensional indicators of both. So suicidal ideation, we have 5 different types of thoughts, types, yes, no, and then 5 dimensional characteristics of the most severe thought. And suicidal behavior, similarly, we have 5 types of behavior that we're looking at. We're looking whether it's there. And then there's a dimensional indicator of how severe, how lethal, rather, the attempt in particular was. So, and I want to highlight the structure because I think that's one of the real strengths of this particular method. And as I'm saying, this is one method for doing suicide risk assessment. But the undeniable strength, I think, of this method is that you have the term, you have the definition, and you have the suggested questions. In order for us to speak the same language, we have to understand that we mean the same thing. Okay? So let's just look more in more detail what these 4 sections of the method look like. So just to highlight 5 types of ideation, from wish to be dead to non-specific thoughts of killing oneself, and then what would be called active ideation with method, then with intent. And I will go over these in just more detail in just a minute. Okay, so you know what? I realized that I didn't turn my timer on, so how am I doing on time? Okay, all right, great. Thank you. So, okay, so what you're looking at right now is the suicidal ideation section that asks about 5 types of thoughts. The first 2 questions are really the screening questions, and you first ask whether a person wishes to be dead, and then you ask about whether they have any thoughts of killing themselves. And if the answer is yes to the question about killing, wanting to kill oneself, then you ask about the type of active thought that they're actually having. Do they have a method in mind? Do they have a specific plan? And we'll look at these in more detail. So, have you wished you were dead or wished you could go to sleep and not wake up? Have you actually had any thoughts of killing oneself? Third type of thought, have you been thinking about how you might do this? So, let's pause and think, what is the difference between, what is the transition from 1 to 2? The transition from 1 to 2 is, 1 is wishing to be dead to 1 thinking about becoming an agent of carrying that desire out. That's the transition from what historically was called passive ideation to active ideation. So you are thinking about becoming an agent. And the subsequent 3 types of active ideations, thoughts, the first one is method. The next one, do you have any intention to act on these thoughts that you're having of killing yourself? And then the most severe level would be, have you started to work out a plan for killing yourself, where you're pretty specific about time and place and confident, reasonably confident, or forget reasonably confident, that you have intent, some intent on acting on these thoughts. So let's just look at an example. The patient thought about dying and how easy it would be to pretend to fall in front of a bus before so that the death would look like an accident. Although he thought about it often, he said he did not have the courage to do it. What do we think this is? All right, so with the kids, and some of this really applies, not just the kids, the very important thing for all of us, and again, this is the message about trying to leave your subjective thoughts about what this might be outside. You have to figure out or you have to ask what the person you're interviewing is believed about what was going to happen. So the example that I usually give is that one of my little kids I talked to believed on the inpatient unit, believed that she could cut off her circulation with a bunch of rubber bands. Most of us will think, not a big deal. Like, you can't really die by wrapping some rubber bands around your wrist. But the point here is not to judge the lethality. The point is to figure out what the intent was. So when that girl tells me, yes, I wanted to die, that's what matters in terms of figuring out what the meaning of the behavior was. Okay, the intensity of thoughts, this is when we figure out what type of thought the person is having, and then we try and characterize it in terms of its intensity. And these are these are the parameters: the frequency, duration, controllability, deterrence, and reasons for feeling the way that they're feeling or having these thoughts. So this is how the intensity of ideation looks. You have it in the slides as well, and I'll just walk you quickly through how you would go about asking these questions. So let's just say you asked the person, and they said, yes to wish to die, yes, I've been thinking or I've thought about killing myself. And then you proceed to the last three questions, and the person says, yes, I've been thinking about how I might do this, let's just say pills. And then when you ask the subsequent questions, the answers are no. So what happens with intensity is that you take the most severe thought. In this case, in this person's case, let's just say they were thinking about killing themselves by ingesting pills. That means the most severe type is 3. And then you start asking questions about, well, how frequently have you been thinking about this? How long do these thoughts last? And so you go through these 5 questions and obtain a total score. And do we have a cutoff for what's bad, what's super bad, what's sort of bad? No. It really varies by clinical population. If you're working with suicide attempters, the meaning of these numbers will change. The general, of course, interpretation is that the higher the total score, the worse the person is. So, in some assessments, we don't look at intensity, but the evidence that is accumulating is that intensity might actually be a stronger predictor of suicidal behavior for certain groups. So we've definitely seen that with adolescents. I mean, this is a study from an inpatient unit by one of the colleagues at University of Michigan. But this is not just the only group that is finding this Anthony Spirito's group recently came out with a publication also suggesting that suicidal ideation in adolescents particularly might have more dimensional quality than in adults. So Nicole already suggested that it is important to know and differentiate suicidal versus non-suicidal. So in the suicidal behavior, we first ask about actual attempt. Have you made a serious attempt? Have you done anything to harm yourself? So these are some suggested questions that you could be asking, and I'll go over the definitions in just a second. And then there's also a question, and this is where you, as an interviewer, you do have to make a decision in distinction between whether the self-injurious behavior is attempt or self-injurious behavior with no suicidal intent. And I'll just walk you through that in just a minute. Okay. So, suicidal attempt. So under this conceptualization, and there are good reasons for defining suicide attempt this way, the definition is this: a potentially self-injurious act committed with at least some intent to die as a result of the act. There are some important changes in that definition from the historical definitions that we've had of suicide attempt. Notice potential, notice some intent. Okay? So the non-zero intent to die was probably the biggest change in the thinking, and we don't necessarily all agree in the field, but nonetheless, there's plenty of evidence to say that there is a good reason to use a non-zero intent as a criterion. So even if you want, even if a small part of you in the back of your mind did whatever you did with a little bit of an intent, we thought, yeah, maybe I want to die. For us, that is suicidal attempt, okay? And potential for injury, why focus on potential, is because there are many instances when there is no injury. Think of rubber bands. Did this girl hurt herself? Not really. Was it a suicide attempt? Yes. And it's a real change in thinking. It's a real change in our description of what suicidal ideation behavior would be. And of course, the intent and behavior have to be causally coherent. They have to be linked. So you undertook a certain behavior because at least part of you, or at least a little bit of you, wanted to die. Okay? So just to highlight that, this is not a total agreement. If you look at the American Psychiatric Association current definition, this is the definition: self-injurious behavior with non-fatal outcome accompanied by evidence, implicit or explicit, that the person intended to die. So that if you ponder this definition points to a much stronger evidence for suicidal intent than a non-zero criterion that I just gave you. So even though I said that we try, one of the raison d'etre, one of the important reasons for this method is to take subjectivity, our raters, our clinicians, our interviewers, subjectivity out of describing or deciding how to describe. There are two instances where if a person denies intent, that you can very reasonably infer that the person was in fact suicidal. And particularly this one, I think, well, in practice, I've certainly used this question many times and have been surprised at the change in the rating just because of the answer. No, I didn't want to die. No, 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 I did not want to die. Well, did you think that if you took this many pills or when you were collecting them, did you think that you could die from it? If the answer is yes, you can say that they knew the possibility, and that really suggests that there was at least part of them that was had suicidal intent. Okay, and in certain cases, and this is less clear, but in certain cases, the clinical circumstances are such that there's no other intent that could be conceived of by rational reasons. So the example that comes up in our presentations often is soldier denying suicidal attempt after shooting himself in the head. There are a lot of consequences to admitting negative consequences or perceived negative consequences for soldiers, for example, the military, to admitting suicidal behavior. So this particular gentleman was really adamant about not having attempted. Okay, so distinction really ultimately comes down to non-zero versus zero intent. Okay, if the behavior was undertaken purely for other reasons, it would be non-suicidal self-injurious behavior. And in research, I have to say, just fast forward a little bit, even though in Europe there's a tendency to merge the two, in surveillance work and research, the non-suicidal and suicidal injury, what we see in, I think, empirical literature on treatment efficacy is that it's important to delineate and differentiate the two. Some interventions, and maybe some of you are familiar with the study, just came out, meta-analysis of treatment studies of different types of treatments for suicidal ideation and behavior. There was a different pattern depending on the outcome you were looking at. For non-suicidal self-injurious behavior, most of these treatments didn't do anything, didn't work. For suicidal attempts, there was efficacy, okay? So this differentiation does have an important effect on how we construct and conduct our treatments. Okay, so this is just an illustration where we get to that. Okay, so the implications, there are several implications that I already started. In practice, clinicians tend to underplay significance of non-suicidal self-injurious behavior and often end up giving less thorough evaluation of these patients. And in many patients, including patients with borderline personality disorder, again, recognizing heterogeneity within the borderline personality disorder diagnosis, nonetheless, non-suicidal self-injury could be a more significant predictor of suicidal attempt and suicide death. So, and what we do know is that when non-suicidal self-injury has internal motives, when it's done in isolation, when it's more frequent with more methods, and when there's less pain felt, those parameters or those indicators allow you to conclude that the person is at much higher risk from engaging in non-suicidal self-injury. Okay, the patient cut her wrists after an argument with her boyfriend. Suicide attempt or no? Okay, let's see if anything changes for you. Anything change for anybody? No, yes, can I hear no, yes? No. All All right. Okay. So again, this is getting at the idea that lethality, level of intervention does not tell you whether suicidal behavior is suicidal. Okay, a woman had a big fight with her ex-husband, took 20 pills, went to bed, slept through the night, 5 p.m. next day, woke up, stated couldn't stand up or walk, called EMS, went to ER, stomach was pumped, unable to verbalize clear intent, but stated she was aware of the dangers of overdose and the potential for death. All right, okay. So, all right, other behaviors. And I'll tell you, I'll be the first to admit that I was not trained to assess for these. You know, went to a pretty good graduate program, not trained. And when I talk to my friends and colleagues in psychiatry, many times I hear the same thing. Never asked about whether somebody tried but stopped themselves. Okay? So, several behaviors that are important. They're predictive of suicidal behavior. They're more frequent than suicide attempts. Some of them, like self-interrupted attempts, in certain cases may be even more dangerous than history of attempts. No, sorry, not self-interrupted, interrupted by others. When a person starts to take steps to end his or her life, but something stops him, has there been a time when you started to do something to end your life, but someone or something stopped you before you actually did anything? Okay? So self-interrupted, similar idea, but you stopped yourself. Okay? And again, think back to the nutshell slide. Term, definition, suggested question, suggested probe. Okay? And then there are a couple of examples that I offer here that somebody driving and then stopping, changing their mind. No, I'm not gonna actually go through this. Okay, and one important distinction is that the harm or the potential for harm, and this is difficult, cannot start. In order for behavior to not be to be termed interrupted or self-interrupted. For example, if somebody takes one pill and changes their mind, you would still call it a suicidal attempt because the potential for harm has begun. In interrupted or self-interrupted behaviors or preparatory behaviors, the harm has not started yet. Okay, that's also a critical distinction. Okay, so preparatory behaviors, again, something that never asked in my training. And you'd be surprised. No, never attempted. No, and never tried. No, never really started and stopped. Well, have you collected pills? Have you, just in case, you know, have you written a suicide note? And you'd be surprised the answer could be yes. And unless you ask specifically, objectively, with no kind of presupposition based on absence of suicidal attempt, you might get to that answer. And we've certainly seen cases like this where a person was evaluated in the clinic, no suicidal behavior. Turns out that he already packed up all his clothes at home in bags to be given away. But no, hasn't started anything, hasn't interrupted himself, and has not attempted anything yet. Okay? All right, so a woman fills her monthly prescription for an antidepressant early. She's saving her extra medication for the future in case she needs a way out. Yeah. Okay, a girl was in her room with a bottle of her mother's sleeping meds in her hand, planning to take them in the hope of dying. The girl's mother came in and stopped the girl before she ingested any. Right, okay. So, the behavior definitions are very similar now to CDC. CDC worked very closely with Columbia, and the surveillance that is happening now suicidal behavior really refers to the suicidal behavior definitions that I just covered. Okay, so this list of terms that CDC really discourages from using goes back to the point about objective description. Okay, we can agree or disagree whether there's a reason, good reason to use some of these, but just to make the point, failed attempt. We don't want people to be successful, okay? This is not a failure, okay? We don't, and we don't want success either, okay? And even though, you know, I'm not going to go through all of these, but the main point is the one that I just gave you. And certainly this is pretty understandable that, you know, calling a behavior hostile is not the way to go about classifying. Okay, so lethality. The main point here is that there is actual lethality and potential lethality. Okay, and actual lethality really is how severe is the medical damage that you can see, tissue, hospitalization, etc. But what's particularly important is to look at potential lethality. Again, rubber band example is one extreme of, you know, potential lethality was probably pretty low. Well, not probably, it was very low, next to zero. But what if somebody was laying down on the tracks and for whatever reason miscalculated the train schedule? If that train came, there was no way that person was going to survive. So the potential lethality was lethal. Okay, so comparing this method to some others that are out there, PHQ-9, great depression screener, has one question, and the screener is really tied to the DSM criteria for depression. So one domain is suicidal ideation behavior. So this is the question: thoughts that you would be better off dead or of hurting yourself in some way. Now that I've walked you through, do you feel like this is a sufficient question to get at ideation and behavior? Okay. So, based on what I just, I think, described to you, this question does miss most types of suicidal ideation and behavior and does not differentiate between suicidal and non-suicidal behavior. We can once again argue whether better off dead is suicidal thought or not suicidal thought. Under this conceptualization, it's not a suicidal thought, but certainly is a morbid thought. But once again, this is, we can have that conversation. For the sake of time, I'm not going to launch into it. So, and some of the empirical studies that we've looked at have shown just that very difference, that the rates that you get based on the one question are very different compared to more delineated way of looking at ideation behavior. Okay, so one example is 200 patients with depression that came through our hospital, and look what happened. So this is C-SSRS. Almost 30% of patients with suicidal ideation were not detected by regular clinical interview, right? Just open-ended, etc. And almost 20% with a history of an attempt. Okay? So this is a very recent study by Greg Brown and Barbara Stanley, who's going to be speaking in just a little bit. But again, a very poignant result where even in the situation where there was a pretty high agreement, like higher than you would normally expect, there was a discrepancy in the ratings of suicidal attempts and regular clinical assessment, okay? What I'd like to highlight, I know this is like almost broken record, but, oops, sorry. What I would like to highlight is that the cases that were missed by regular clinical assessment had lower lethality than cases with better agreement. What does it tell us? That we're still referring to how badly did the person get hurt as our criterion for defining suicidal behavior, okay? So rubber band example again, right? Okay, so with this method, it does become somewhat easier to develop clinical guidelines, even though, again, when you're working with different populations, different groups, the thresholds, the cutoffs are going to be different. But the general rule of thumb is that once a person has active suicidal ideation with any intent to act on their plan, they're in a different category in terms of risk, okay? And I've outlined some caveats. I don't know if I have time, probably don't. Okay. So I'm not going to go through the different caveats because there are statistical caveats to how you think about risk. But hold on. Yeah, so this is basically the last slide, so maybe I'll tell you a little bit. So the difficulty with instruments, with methods that look at suicidal ideation behavior is that we're working with a very scary phenomenon, but a rarely occurring. I mean, we don't feel like it's rarely occurring, but statistically speaking, this is not diabetes, for example. And statistically, what that translates to is that our methods do not have a very high probability of actually picking up the patients who will go on to attempt. And I know this doesn't sound very encouraging, but there is a statistical reality to this work, and the importance of full risk formulation, and this is what I started with. This is risk assessment. There's a difference between risk assessment and risk formulation. So for a full risk formulation, you're not just going to look at ideation and behavior. You're going to look at a whole host of risk factors and relevant to our conversation today, borderline personality disorder. Once again, like the study that I was referring to in terms of efficacy of different therapeutic approaches that exist to suicidal ideation behavior, one moderator or one group for which treatment worked was borderline personality disorder patients. That was one of the moderators, okay? So this is just an example of how some of these guidelines get articulated or integrated in some of the systems. This is a beta testing, so to speak, of New York State electronic medical record, just to show you that, for example, for Medicaid patients, the state can mandate how they're going to be assessed. You know, speaking of like bringing healthcare together in different sectors. And so they are looking at these particular rules for deciding on the level of risk. So the point that I'm making is that the risk will fluctuate, the risk will vary based on the clinical population or non-clinical population that you're working with. And but this particular method helps you describe more objectively the phenomena that you're working with, or you're seeing, or you're encountering, and it prepares you, I think, better prepares you to move on to risk formulation. Okay? All right. Thank you so much.